Chloe, I'm a 5th year at Imperial, and this presentation's on delirium versus dementia. So case 1. Mr. AD is an 80-year-old man and he presents to A&E confused and agitated, accompanied by his wife. She says that he's become aggressive a few hours ago and is now dipping in and out of consciousness. She's concerned because he cut his hand this morning on a rusty nail while gardening, and she thinks the two might be related. And that's because his hand looks like this. It's red, it's hot, swollen and painful. And on examination he appears septic. He has a reduced GCS, is dehydrated, a low blood pressure but a high heart rate. He has an elevated white cell count and raised inflammatory markers. So in this instance, Mr. AD has cellulitis that's led to sepsis and subsequently delirium. Delirium is an acute fluctuating syndrome of disturbed consciousness, attention, cognition and perception. So to break that definition down, it develops over hours to days. The patient isn't fully aware of or in touch with their environment. They have a reduced ability to focus, direct, sustain and shift attention. They may have a memory deficit, they may not be orientated, and they may have language issues. And there may be misinterpretations, illusions, and psychotic features, so hallucinations and delusions. Delirium is really important because it's a medical emergency, and around a third of patients die during an episode, so it's very important that it's managed and recognised correctly. There's a huge number of causes of delirium. It's essentially anything that disrupts homeostasis, so this is in no way a complete list. But there are infective causes such as sepsis, meningococcal disease, indwelling catheters, cellulitis, which was in this case, drugs such as anticholinergics, benzos, opiates and alcohol, poisoning from carbon monoxide, heavy metals such as lead, metabolic causes, for example dehydration, electrolyte disturbances, acute kidney injury, low blood sugar, hypoxia, and many different endocrine conditions. Nutritional defects such as venous encephalopathy due to thiamine deficiency in alcoholics, and trauma, especially hip fractures and major surgery, but also complications of epileptic fits. So investigations, you want to take a collateral history, you want to assess the mental state of the patient, you want to do physical examination to really gauge any signs of infection, and then you do the appropriate blood tests based on the history and the examination, but it's quite a wide spanning range of tests. You'll look at the urine, do a dipstick and MSU, and looking at the chest x-ray if indicated. So for example, if you presume that this patient has pneumonia that's causing delirium. So to manage, you treat the underlying cause. So in this case, you would treat the cellulitis, but you also need to manage aggravating factors. So pain, dehydration, constipation, because these factors all exacerbate delirium. You want to stop any unnecessary medications, and if they're very agitated, you may require short-term sedation. So you could use a typical antipsychotic such as haloperidol or benzos very short-term. But obviously if the benzos are causing the delirium, you wouldn't give them anymore. And in some instances where it's quite severe or prolonged, you may consider referral to geriatrics or psychiatry for more specialist input. On to our next case. Mrs. SC is a 70-year-old woman, and her daughters persuaded her to come into the GP. And that's because yesterday Mrs. SC left her bath taps running and flooded her house. And she insists it was a one-off mistake, but her daughter tells you that it happened a few months ago, which was around the time that SC actually had a stroke. And her daughter's also worried because over the last week her speech appears to have slowed down. On examination, she has a high blood pressure and she has left-sided weakness on her cranial nerve exam. So when you ask her to smile, this is what her mouth looks like. So it's clear that Mrs. SC has cardiovascular diseases, and in this case it's actually caused vascular dementia. So for dementia we'll discuss the four most common types. So there's Alzheimer's, vascular, Lewy body and frontotemporal dementia. And frontotemporal dementia is an umbrella term that includes many different diseases, including Pick's disease and progressive supranuclear palsy. Dementia is defined as an acquired, chronic, and progressive deterioration of cognitive function due to organic brain disease, and this has to be sufficient enough to impair activities of daily living. So that means things like managing money, hygiene, cooking, cleaning, mobilising, and looking after yourself, really. And the impairment has to be within at least 2 cognitive domains. So in the case of our patient here, that was memory and language, but you also may have behavioural issues, visual-spatial issues, or issues with executive functioning. And unlike delirium, dementia is chronic, it's irreversible, and you have no impairment of consciousness. So firstly, Alzheimer's disease, it's the most common type of dementia, and it has a gradual onset with progressive cognitive decline, and you have an early memory loss. So in terms of pathology, there's degeneration of the cerebral cortex with cortical atrophy and a reduction in acetylcholine production. You will see beta amyloid plaques between neurons and neurofibrillary tangles of hyperphosphorylated tau inside neurons. The second most common type of dementia is vascular. So here you'll see focal neurological signs and symptoms with evidence of cerebral vascular disease, so strokes or TIA, which is what this patient had. And there may be uneven or stepwise deterioration in cognitive function. And that's because you get brain damage due to several incidents, and these may be multiple small infarcts or a large single infarct, or they may be strategic, which means that they occur in a particularly important area of the brain, so a small bit of damage causes a really significant effect. Lewy body dementia is slightly different to the other two because in this one you have a fluctuating picture. So you'll have fluctuations in cognitive performance. You'll have recurrent visual hallucinations. These tend to be very colourful, vivid, and often about animals. So that's quite a buzzword there in exams. And you often see motor signs of Parkinsonism, so cogwheeling and pill rolling tremor. And these can't be attributed to a drug. Other supportive symptoms that you may see is REM sleep behaviour disorder, which is where the patient has very vivid dreams and they may respond by making quite jerky movements in their sleep. And they may have fits and faints and transient disturbances of consciousness. They'll have mild atrophy in frontal, parietal and occipital lobes, and you'll see deposition of abnormal proteins called Lewy bodies in the cortex. And Lewy bodies are intracellular aggregates of alpha-synuclein and ubiquitin. The last type of dementia is frontotemporal dementia, or you may know it as Pick's disease. And here you have behavioural variants. So you'll have an early decline in social and personal conduct, which may be represented as disinhibition. There may be dietary changes, so these patients tend to show an increased preference for sweet foods. And there may be early emotional blunting and a loss of insight. So really primordial instincts kind of tend to predominate the actions of these patients. And there may be primary progressive aphasia, which is non-fluent, and semantic variants. So essentially you have attenuated, so reduced speech output. So there may be echolalia, which is where a patient just directly repeats what you've just said back to you. Perseveration, which is where the patient repeats sounds. Mutism, loss of semantic knowledge and naming, so kind of a loss of long-term memory there. Here you'll see atrophy of frontal and temporal lobes, particularly the anterior frontal lobe. And there may be intracellular aggregates of tau, TDP or FUS. So to investigate dementia, again you want to do cognitive assessments. So the ones that you're probably most familiar with are AMTS, MMSE and MOCA. You need to rule out delirium because with everything in psychiatry, it's essential that you rule out organic causes first. And if you're really struggling to differentiate between dementia and delirium, then two useful tools are the long confusion assessments method and the observational scale of level of arousal. In some instances, you may consider structural imaging to aid diagnosis, and these are dependent on the type of dementia you're suspecting. So in Alzheimer's, you may decide to do a PET scan, and in vascular dementia, you may decide to do an MRI. For management, you can't cure dementia, so the focus is really on quality of life. So a lot based on emotional and social care, with day centres, meals on wheels, providing Dosset boxes, removing hazards in houses, so those preventing taps from running all day and people accidentally setting off gas cookers. Education, not just of the patient, but also their family and loved ones, because dementia is very difficult for the whole family to manage and deal with. And you want to optimise the patient's physical health and provide respite care. In terms of therapies, there are a lot of different options. So there's group cognitive stimulation, which is memory training and relearning. You may consider group reminiscence therapy. You could consider cognitive rehab and OT, which is especially for aiding with those activities of daily living. Validation therapy can really help with self-esteem. And multisensory therapy is something you would consider for quite severe progressive disease. In terms of psychotropic medications, the mantra in old age psych is low and slow. So you'd start on a low dose and very gradually increase it. For Alzheimer's disease, if it's mild or moderate, you can give acetylcholine esterase inhibitors, such as donepezil and rivastigmine, and these provide symptomatic relief. For severe Alzheimer's, you can give memantinine, which is an NMDA antagonist. For Lewy body dementia, again, donepezil and rivastigmine are the drugs of choice. For vascular dementia, you wouldn't actually give any medicines. You would only treat if you're suspecting a comorbid additional dementia to be present. And for frontotemporal dementia, you don't give any drugs. And importantly as well, for Lewy body dementia, you never give antipsychotics because that can really make the patient very confused and exacerbate illness. So in the simplest way possible, both delirium and dementia cause cognitive impairment, but delirium is acute and consciousness is impaired, whereas in dementia, the disease is chronic and consciousness remains intact. So this is a flow diagram from Crash Course Psychiatry textbook, and this kind of demonstrates this quite clearly. And another thing that this diagram demonstrates is the need to rule out additional psychiatric comorbidities, especially depression, as very depressed elderly patients can develop pseudo-dementia, which mimics true dementia. So in SBA, which of the following is not associated with Alzheimer's dementia? So cortical atrophy, intracellular aggregates of alpha-synuclein, reduction in acetylcholine production, beta amyloid plaques between neurons, or tau deposition inside neurons. So the correct answer is B, and that's because intracellular aggregates of alpha-synuclein are Lewy bodies, so they're seen in Lewy body dementia, not Alzheimer's. And this is another summary table that really summarises this entire presentation, again from the Crash Course Psych book. And that's what has been referenced throughout this PowerPoint and as further reading, alongside the PRN, NICE guidelines and 100 Cases in Psychiatry book. Thank you.